We're now going to talk about ENT emergencies and miscellaneous. A 45-year-old lady with a history of a recent tooth infection shows up with a huge, hot, red, tender, fluctuant mass occupying the left lower side of the face and upper neck, including the underside of the mouth. The mass pushes up the floor of the mouth on that side. She is febrile. This is an abscess, obviously. But an abscess in this location, under the floor of the mouth, we call it Ludwig's angina, has more than the usual indication of what to do, which is to drain the abscess. It has a potential to affect the airway. So that the correct answer here is one that drains the pus and makes sure there is an appropriate airway. Intubation or perhaps even tracheostomy may be appropriate depending on the circumstances. And vignette number 20. A 29-year-old lady calls your office at 10 a.m. with a history that she woke up this morning with one side of her face paralyzed. We know that that typically means Bell's palsy, benign, self-limiting process. She will recover from this. Why is this here among emergencies? Well, there are some people in ENT who treat these with antiviral medication. There's a feeling that perhaps a viral infection is responsible for it. And if you are going to use antiviral medications, they don't do any good if you delay their use. This is generic to antiviral medications. You know that when you're going to use antiviral medication, it's got to be right away. And that's why this is here. Vignette number 21, a patient with multiple trauma from a car accident is being attended to in the emergency room. As multiple invasive things are done to him, he repeatedly grimaces with pain. The next day it is noted that he has a facial nerve paralysis on one side. If a patient comes in, severe trauma to the face, severe trauma to the bones in the skull, and at the time of admission the patient has facial nerve paralysis, obviously there has been damage to the facial nerve from whatever fracture existed in the area. But if the vignette, like this one says, when he came in and he was attended to, he had perfectly normal function of his facial nerve. He was making all the usual expressions. And then the next day he has a paralysis. This is then swelling. This is edema of the nerve. And no intervention is required. Vignette number 22. Your office receives a phone call from Mrs. Rodriguez. You know this middle-aged lady very well because you have repeatedly treated her in the past for episodes of sinusitis. In fact, 6 days ago you started her on decongestants and oral antibiotics for what you diagnosed as frontal and ethmoid sinusitis. Now she tells you over the phone that ever since she woke up this morning she has been seeing double. That's an ominous thing. You knew there was pus there in the frontal sinus. That pus has either gone backwards into the cavernous sinus or sideways into the orbit, either of which is bad. So you need to do CT scans, find out exactly where the pus is, drain it surgically, IV antibiotics. This is a big deal. Vignette number 23, a 10-year-old girl has epistaxis. Her mother says she often picks her nose. Indeed, in that age group, we expect epistaxis to be due to direct trauma. It's in the anterior part of the septum. It will respond to anterior packing or vasoconstrictors applied locally. In contrast to that, vignette 24, an 18-year-old boy has epistaxis. The patient denies picking his nose. No source of anterior bleeding can be seen by physical exam. In this age group, you have to suspect two more ominous things. One possibility is septal perforation from cocaine abuse, and the other one is a tumor called a posterior juvenile nasopharyngeal angiofibroma. The former may need posterior packing, the latter needs to be surgically removed. They are benign, but they can eat away at nearby structures. And there is yet another presentation for nosebleeds that can be very significant. A 72-year-old hypertensive man on aspirin for arthritis has a copious nosebleed. His blood pressure is 220/115 when seen in the ER. He says he began swallowing blood before it began to come out through the front of his nose. This is obviously epistaxis secondary to hypertension. These can be very serious. People have died from these. Medical treatment to control the hypertension is clearly needed, maybe one of the options offering the answers. But getting the ENT people there right away is also part of the equation. They will need to do posterior packing, and in some cases, emergency arterial ligation may be required. And the last two vignettes have to do with patients who report that they are dizzy. You know, patients use the word dizzy in a very non-specific way. If they feel weak and faint, they may say, I'm dizzy. If their equilibrium is affected, they may say they're dizzy. If they have vertigo, they may say they're dizzy. So let's look at a couple of vignettes so we can make a little bit here of a differential diagnosis. Vignette number 26. A 57-year-old man seeks help for dizziness. On further questioning, he explains that he gets lightheaded and unsteady, but the room is not spinning around. In vignette number 27, a 57-year-old man seeks help for dizziness. On further questioning, he explains that the room spins around him. The first of these two has a problem affecting the brain. He doesn't have a vestibular problem. But the second, the one who says the room is spinning around him, has a vestibular problem. Let's remind ourselves of that by looking at a couple of screens that have words in them. A patient reports dizziness. If the patient is lightheaded and unsteady, but the room is not spinning around, it is a neurologic problem. But if the room is spinning, it is a vestibular problem. And this is the end of ENT emergencies and miscellaneous.